Hey, welcome to Not So Complicated, and it's day 4 clinical case discussion 4, and we are tapping into the series of Diagnose with me. So let's begin. A 45-year-old male presents to the emergency department with a 12-hour history of severe epigastric pain radiating to the back, nausea, and vomiting. He denies trauma, hematemesis, or recent alcohol use. His medical history includes gallstones diagnosed 2 years ago, asymptomatic, hypertension, and smoking 15 pack years. Medications include hydrochlorothiazide. Social history reveals moderate alcohol use 2 to 3 drinks per week and a high fat diet. So he was diagnosed with asymptomatic cholelithiasis 2 years ago, and he is now presenting a severe epigastric pain. Maybe he is having severe acute cholecystitis, maybe, because he also have a high fat diet. Let's tap into other informations. Vital signs are normal. BP is normal, and heart rate is 105 beats per minute, which is raised, and respiratory rate is 20 per minute, SpO2 97 percentage, which is absolutely good, and temperature 38.1 degrees Celsius. Physical exam shows epigastric tenderness with guarding, no rebound tenderness, and negative Murphy's sign. Bowel sounds are decreased. So Murphy's sign is negative, which means we what we expected to be acute cholecystitis is might be wrong in here, because Murphy's sign is done to elicit the pain. If it was for acute cholecystitis, the examiner places hand over the subcostal region in right hypochondrium, and then the patient is asked to breathe in, and we can see the clean breathe cat's expression in their face if it was acute cholecystitis, but it doesn't happen in this case. So Murphy's sign is negative. Let's go into the labs. WBC 14,000 per microliter, hemoglobin 13 gram per deciliter, mileage 900 units per liter, which is very high to the normal limit, and also lipase is also very high, 1200 units per liter, normal 10 to 140. ALT is almost normal, AST normal, total bilirubin is 1.0 mg per deciliter, and alkaline phosphatase is 90 units per liter. So amylase and lipase are increased, and everything else seems to be quite normal. So maybe it is a case of pancreatitis. Abdominal ultrasound shows gallstones, no gallbladder wall thickening, and a common bile duct diameter of 5 mm. What is the most likely diagnosis, and what is the next step in management? Okay, let's tap into the options and let's debunk each of the options, eliminate and choose kind of thing that we do usually is per our last videos. Let's go into that. The options are acute hepatitis, order viral serologies, acute cholecystitis, administer IV antibiotics and consult surgery, cold cholelithiasis, perform ERCP, and peptic ulcer disease, start IV proton pump inhibitor. Also acute pancreatitis, initiate IV fluids and pain management. Okay, case recap is attached in there. So option A is acute hepatitis, order viral serologies. Okay, let's debunk that. If it was hepatitis caused by viral or alcoholic hepatitis, it would give right upper quadrant pain, but it is severe epigastric pain in this case, and there should be jaundice, but there is no signs of jaundice. ALT and AST is normal in this case, which would be rising up to greater than 100 to 1000, and also bilirubin would rise up if it was hepatitis. And here ALT is 40, AST 45, bilirubin 1.0, liver is absolutely fine, epigastric pain, amylase or lipase spike, probable pancreas obviously, yeah, and there is no heavy alcohol use, which means there is no alcoholic fatty liver syndrome or cirrhosis in here. And serologies, HAV, hepatitis A virus, hepatitis B virus are for liver chaos and not this. In the USMLE trap, smoking mild alcohol teases hepatitis, but normal LFTs plus pancreatic enzymes shut it down. So it is very highly unlikely. If it was hepatitis, signs and symptoms should be yellowing of the skin and the whites of the eyes because of the bilirubin attachment in the bulbar region of eyes. So off note, the bilirubin gets attached to the collagen of bulbar region, sclera of eyes, so it appears yellow, and there should be headache, fever, enlarged liver, and right upper quadrant abdominal pain, and joint pain, clay colored stool, dark urine should be there. So it is not our answer. Let's go into the other option, which is acute cholecystitis, which we expected in the first place, and administer IV antibiotics and consult surgery. Let's debunk it. Cholecystitis loves right upper quadrant pain, positive Murphy sign. There is negative Murphy sign in this case. Ultrasound with thickened gallbladder wall. The gallbladder wall is not thickened even though there is gallstones, which means that the gallstones are not large enough to irritate the gallbladder to cause its fibrosis. And also there should have been pericocystic fluid, which is not also present in here. Here, pain is epigastric, not auric. Murphy is negative, and ultrasound is normal, just stones is there. And amylase lipase is not cholecystitis, more pancreatitis obviously, and antibiotics or surgery fit severe cases, empyema, not this. USMLE trap, gallstones tempt you. 70% of cholecystitis cases have them, but enzymes scream pancreas in this case and not gallbladder. So acute cholecystitis in ultrasonography shows like the picture I have attached in there. There is thickened wall and also the stone in there, and the wall is greater than 3 mm. Pericholecystic fluid is also present. It gives positive sonographic Murphy sign. And off note, there if it was a gallstone, the gallstone is posing a posterior acoustic shadow in there. If you can see it in the yellow line, the just behind the stone. And so this might be likely, but it is not a case of acute acute cholecystitis. I can say that because of the Murphy sign and pain region and normal liver findings with no signs and symptoms in there. Still, let's go to the third option, which is called docholithiasis, perform ERCP. Docholithiasis means the the gallstones are in the biliary tract, intrahepatic or extrahepatic biliary tract. So in the picture I have attached in there, cholelithiasis means it is that the gallstones are present in the gallbladder, and hepatolithiasis means there are in small bile duct, and docholithiasis means it is in common bile duct. Also, let's debunk this option. Common bile duct stone causes jaundice, increase in bilirubin, ALP dilated, CVD greater than 6 to 7 mm, but CVD is normal in this case, which is 5 mm in diameter, and bilirubin and ALP are also normal. ALP, which means alkaline phosphatase, increases if there is obstructive jaundice due to the irritation of the gallbladder wall or the biliary tract wall, and it expresses the gene for ALP synthesis. So it doesn't happen in this case in here. And here bilirubin is normal, 1.2 ALP is normal, CBD is 5 mm, all normal. There is no obstructive signs, no fever, no jaundice. Triad for cholangitis. Cholangitis has triad of symptoms. The triad of symptoms of cholangitis are rigors, fever, and jaundice. And also amylase or lipase fit pancreatitis, not duct blockage. ERCP, which means endoscopic retrograde cholangiopancreatography, is for stones or leaks. It is not for mild pancreatitis. USMLE trap. And here is gallstones bet you to our CBD stone in 10% of gallstone pancreatitis, but normal labs or imaging say no, and ERCP is premature, which means USMLE test restraint. So this is very unlikely. And the other case is peptic ulcer disease, start IV proton pump inhibitor. So peptic ulcer disease causes epigastric pain. Yeah, it causes it, but burning, not radiating to the back. So in our case, the pain is radiating to the back. And also there is no history of hematemesis or melena if there was peptic ulcer bleed signs or GI bleed signs. And also amylase or lipase are screaming pancreatitis obviously, because peptic ulcer disease present with normal enzyme levels, and PPI, which is proton pump inhibitors, are for bleeding ulcers, not this inflammatory vibe. And smoking fits but enzymes rule. And USMLE trap, epigastric pain and smoking tempt peptic ulcer disease, but enzymes are the giveaway. So this is very highly unlikely. Peptic ulcer, complications of peptic ulcer can be perforation or pyloric obstruction, bleeding due to internal hemorrhage. It can happen in this. And the last option that we have is acute pancreatitis, and the management option is initiate IV fluids and pain management. Okay, so this is the diagnosis, we can say that, but let's debunk it too. Pain to back, nausea, vomiting, amylase 900, lipase 1200, gallstones and ultrasounds is the etiology for acute pancreatitis in here. The gallstone in gallbladder dislodged because it was smaller in size, and the dislodged gallstone traveled to the pancreatic duct and blocked the pancreatic duct in there, and caused the pancreatitis due to the irritation. So WBC is 14K and fever 38.1 degrees Celsius means there is inflammation, and SR is 105 minutes fluids because hypovolemia from vomiting, and third spacing. Third spacing, we will talk about that in later. And morphine eases pain obviously, and there is guarding, which means there is pain. So morphine, we should give morphine to ease pain. And USMLE key diagnosis needs 2/3 pain enzymes, imaging ultrasounds enough here, and fluids first. Prevent necrosis, Ranson's criteria, WBC, glucose, LDS later. So this is the likely diagnosis of our case. And in pancreatitis, clinical findings are elevated lipase, epigastric pain, and imaging findings are peripancreatic stranding, like we have seen in the MRI given in the slide. And it is a case of uncomplicated acute pancreatitis. So the complications of pancreatitis, acute pancreatitis, can be local complications or systemic complications. In local or pancreatic complications, there is abscess formation, fat necrosis, hemorrhages, infected necrosis, and pseudocyst formation. Sterile necrosis can be there. And in systemic complications, acute kidney failure, acute liver failure, ARDS and DIC, encephalopathy, gut ischemia, hypocalcemia, paralytic ileus, shock, all of that can happen is the complication of acute pancreatitis. So our diagnosis here is acute pancreatitis, and the mechanisms, just like I have said earlier, gallstones in 40% of cases block the pancreatic duct, enzyme backup, amylase or lipase, autorization of pancreas happens and it causes inflammation. And other causes, alcohol in 30% of cases, hypertriglyceridemia, drugs like hydrochlorothiazide, but it is rare in here. And the injury it causes is SNR cell damage that causes trypsin activation and fat necrosis, hemorrhage in severe cases, mild cases here, so there is no organ failure. So let's tap into the Ranson's criteria. Ranson's criteria means we have two situations for the Ranson's criteria, and it is on admission and within 48 hours of admission. And in on admission, WBC greater than 16,000 per microliter, age greater than 55 years, glucose greater than 200 mg per deciliter, and AST greater than 250 international units per liter, LDS greater than 350 international units per liter. And each of this criterion is a point is attached to 1 point, is assigned 1 point, and the total points is calculated. And also within 48 hours of admission, HCT means hematocrit decreases greater than 10%, blood urea nitrogen increases greater than 5 mg per deciliter, and serum calcium less than 8 mg per deciliter, arterial partial pressure of oxygen less than 60 mmHg, base deficit greater than 40 milliequivalent per liter, and fluid needs greater than 6 liter. So in this cases also, each of the point is attached to 1 point, and if the points in Ranson score is less than 3, it causes 0 to 3% mortality, and if the point is 3 to 5, it causes 11 to 15% of mortality, and if the Ranson score is greater than or equals to 6, it can cause 40% of mortality, and this is the Ranson's criteria. Another criteria here is BSAP score, which is BUN, impaired mental status, SIRS, age greater than 60, and pleural effusions. And the interpretation is below, and you can look at that. The clinical features of acute pancreatitis is triad, epigastric pain to back 90% in cases, nausea, vomiting in 80%, increased amylase or lipase 3 times the upper limit of the enzymes is 95% is specific. So in this case, pain, vomiting, amylase 900 greater than 330, and lipase 1200 greater than 420, gallstones confirm etiology, heart rate under 5, WBC 14K, fever 38.1 degrees Celsius, and mild systemic inflammation is there, and signs absent. Collins a gray Turner sign, hemorrhagic pancreatitis less than 5%, jaundice There is absence of jaundice because there is no CBD common bile duct block. And the Collins signs, if the hemorrhagic pancreatitis develops, the Collins signs is that the hemorrhagic scenery is in around the umbilicus in there, so it is called Collins sign. And in Great Turner's sign, the blood pools in the flank region of our body in less than 5%, so it is Great Turner's sign. And the picture attached below is that the pain in acute pancreatitis, the typical feature of pain in acute pancreatitis is that it gets relieved when we lean forward, because the pancreas gets compressed if we get into the supine position, and it causes pain. But when we lean forward, because the pancreas is retroperitoneal organ, so when we lean forward, the pancreas gets relieved of the compression, so it does not cause pain. That is why it happens. And also the diagnosis criteria is Atlanta classification 2 by 3, and pain epigastric to back, check. Amylase or lipase greater than 3 times of upper limit, and check. 900 to 1200. Imaging, CT, ultrasound, gallstones, check. Yeah, so here meets all three, but ultrasound is enough. CT for complications in 10% necrotizing cases. USMLE nugget here is lipase is greater than amylase because it has longer half-life and greater than 90% is specific. So if you have two options to tap into the enzymes, you have to choose lipase over amylase. So revised Atlanta criteria for acute pancreatitis here is that the severity cases, it is for severity grading, and in mild cases there is no organ failure, no local complications like we discussed earlier, and there are no systemic complications, typically resolves in first week. And if the case is moderate, it causes transient organ failure less than 48 hours, or local complications or exacerbation of comorbid diseases. And if the case is severe, it causes persistent organ failure greater than 48 hours. This is the revised Atlanta criteria for acute pancreatitis. And the management of acute pancreatitis is by IV fluids because it causes hypovolemic shock. Hypovolemic shock is due to vomiting and third spacing, which develops the risk of organ failure. Heart rate 105, no hypertension yet. Early fluids prevent necrosis in here. So third spacing, what is third spacing? Third spacing occurs when fluid accumulates in a portion of the body from which it is not easily exchanged with extracellular fluid. That is third spacing. It normally happens in acute pancreatitis and obstructed bowel disease. Third spaced fluid is trapped and essentially unavailable for functional use. Examples of third spacing are ascites, and sequestration of fluid in the abdominal cavity with peritonitis and edema due to burns. That is third spacing. And I have also attached what is first spacing and second spacing in there too. You can look at that. And the IV fluids is managed by lactated ringers or ringers lactate 1 to 2 liter stat, 250 to 500 ml per hour rate, and titrate to urine output greater than 0.5 ml per kg per hour. It avoids acidosis, which has because the normal saline is not used in case of ringers lactated because it has the risk of acidosis, so that is why lactated ringers is used. The composition of lactated ringer is attached in there. And in USMLE, fluids first and before imaging, because we have to balance the fluids so that the patient doesn't go into the hypovolemic shock. So 80% is the step 2 questions. We have to choose fluids first before imaging, ERCP or antibiotics. And also the diagnosis, acute pancreatitis obviously. So the pain management should be done because acute pancreatitis presents with severe pain. Guarding needs relief, so we give morphine 2 to 4 mg IV Q4 hour, or fentanyl less sphincter of aorta spasm. It causes, how do we give it? We titrate to pain, monitor respiratory depression. And in USMLE, pain control follows fluids, not before, because we have to stabilize vitals in there. And other NPO, rest pancreas, 48 to 72 hours. We have to monitor Ranson's criteria, admission, WBC, glucose age, 48 hours, HCT, BUN that we discussed earlier. It predicts severity obviously, and we should not use antibiotics in mild cases or if there is no proof of infection. And ERCP, if CBD is stone, 5 to 10% is gallstone pancreatitis, not here because there is normal bilirubin and CBD diameter, which is 5 mm. Cholecystectomy should be done later, 4 to 6 weeks later, and it will prevent reoccurrence, 50% risk without. So that is it for today. Subscribe for the next case discussion, and if you have any queries, or if you have any special requests, you can comment it down and I will cover the same topic in our next video. Thank you.